speakers and participants from other continents because the time is maybe not exactly similar like what we have in Bangkok, Thailand right now. I am Professor Amon Lasmi, your MC this morning and also the moderator of this topic this morning. As you know that the COVID-19 is a pandemic globally, and also it happened in Thailand. Now we have the Delta variant outbreak, and it caused newly infected patients up to more than 20,000 new cases in the last few weeks. But now the number is declining, and we hope that we will be in the good control of COVID-19 very, very soon in Thailand. So COVID-19 is pandemic, and I hope every country will get a good control of it, not very long. Also, tobacco smoking is an endemic for many, many years, and now it's still endemic in many countries around the world. So when we have pandemic and endemic, two diseases occur in the same time in this world right now, we will see what an impact or effect on COVID-19 and tobacco smoking on the lung and the health system. So this morning we will have three speakers, one from Bangkok, Thailand, and the other two from others. So I would like to introduce the first speaker from our host country. We will have Associate Professor Nitipat Tieskun. He is now the President of the Thoracic Society of Thailand under the Royal Patronage. He is also the head division of respiratory disease and tuberculosis at Department of Medicine, Faculty of Medicine, Sirat Hospital, Mahidol University. He is now very popular in the Thailand because he had a critical guidance and issue many education chapter to physicians, Thai people, how to deal with COVID disease, physicians how to manage and to treat COVID-19. So we hear from him this morning about COVID-19 and smoking, what effect or good health or bad health we have. So let's start with Dr. Nitipat Tieskun. Please welcome Dr. Nitipat. Thank you.
Thank you, Professor Amon, our chairperson today. It is my pleasure to speaking here in the 13th APACT 2021 meeting in Thailand, and I'm also proud as to be one of the hosts to welcome guests all over the world. And my talk today will cover the area of smoking and the relation with COVID-19 in my perspective. As Professor Amon has mentioned, I have worked in the field of respiratory disease and tuberculosis in Thailand, and during the past nearly 2 years, we encountered a lot of patients harboring COVID-19, especially during the past 4 months. And there is a controversy about the relationship between smoking and COVID-19 all around the world and also in Thailand. And my sequence of talking today is will concern in 4 areas. The first one will be the risk of COVID-19 from smoking. And the second one is does smoking determine the COVID-19 prognosis or disease severity? And I will add some issue about the diagnostic challenge of COVID-19 among people who smoke, who continue to smoke current smoker or even former smoker. And then I will conclude my talk in what will we have the new normal about smoker during the pandemic or even after the pandemic of COVID-19. Let's start with the figure from Thailand. And this is the figure nearly 3 weeks ago. Thailand had hurry up from nearly the ranking more than 100 to the ranking around 35 within 2 months. We have a lot of patients. Let's start around 100,000 and increase to, at that time, nearly 800,000. And now it's past more than 1 million patients. And Thailand has also in the same situation as another country. We encounter the current smoking problem in our population, and the smoking prevalence is about 20% in the general population, and whether the correlation between smoking and COVID-19 is our speculation also. As we know from our previous knowledge that smoking is a major risk factor for common non-communicable disease, especially in our lung or in our respiratory system, such as the chronic obstructive pulmonary disease or COPD. And also it can potentiate the development of cancer in our lungs. And in Thailand, lung cancer is one of the 3 leading common cancer that cause mortality in male population, and 1 in 5, top 5 of common cancer in female. Thailand also is the country that have intermediate to high prevalence of tuberculosis, and there's evidence that smoking can potentiate the susceptibility to tuberculosis, and also can promote the bad prognosis for tuberculosis also. And also the idiopathic pulmonary fibrosis that may result from infections, toxic irritant or another cause. I mentioned here because now after recovery from COVID-19, there were about 0.5% of the patients that develop post COVID-19 pulmonary fibrosis, and the respiratory physician suspected that people may be resulted in idiopathic, the same or progressive fibrotic disease, interstitial lung disease, some kind of interstitial lung disease in the future. And COVID-19 may promote, we encounter a lot of pulmonary fibrosis after recovery from COVID-19, and many more as a respiratory disease that resulted from continuous smoking. In theoretically, the smoker are at risk of harboring virus infection in our respiratory tract, especially the lower respiratory tract, because the tobacco smoke can cause abnormal mucociliary function, can impair our immune system locally and systemically. And among the people who smoke, there will be cross-contamination when they gather in group. And also tobacco smoke can alter our residual microbiome, and it can enhance some organism to dominate in the microbiome, and it can cause infection, and that can cause consequence after infection also. So the problem is, are smoking and COVID-19 infection, are they friends? They can potentiate each other, and it can cause more injury to the host, to our countrymen. Or are they foe? Smoking can prevent the COVID-19 infection. The smoking can reduce the injury from COVID-19 infection. Let's see the evidence. Initially, after attack by COVID-19 in China, they collect the patients, hospitalized COVID-19 patients, allow 6,000. 55% of them were male, with a median age of allow 40 to 70. They try to extract the prevalence of smoking in this population, and the evidence show that smoking prevalence that revealed in the medical record is just only in the range of 1.4 to 20.6%. And if they add the former smoker also in the plus in the current smoker, the pool estimation of prevalence of smoking is only around 7.3%. This figure is quite low, and it's approximately only 1/4 of smoking prevalence in the general population in China at that time. And there is a concern that whether this data is really, and if it's real, it suggests that smoking may be not related, or even they can protect the COVID-19 infection. Is it resulted from the anti-inflammatory effect of nicotine in tobacco smoke? Because nicotine have the in vitro effect that can decrease the inflammatory effect after exposure to some stimulants. And there's clinical evidence that the patient with some chronic inflammatory disease such as ulcerative colitis and disease can the inflammatory process of the disease is decreased by smoking. And also tobacco smoke can blunt the immune response after we harbor the infection by SARS-CoV-2 virus, because this immunopathogenesis that we call the cytokine storm is the key feature of morbidity and mortality and morbidity among the patient who harbor the infections. And also tobacco smoke can increase the level of nitric oxide in our respiratory tract. As you know that nitric oxide have the role in the inhibit replication of SARS-CoV-2 infection, and also the entering of this virus into the cells. And we during the past month, there's a commercial company. They produce the nitric oxide nasal spray, especially in Canada and in Israel, and they propose the mechanism that nasal nitric oxide nasal spray can decrease the viral number in those who high risk or those who are asymptomatic COVID-19 and can reduce and can decrease the chance for disease progression. But in my view, this phenomenon, as I mentioned, the three phenomena, may be not true in the real world or in the patients. Let's see the evidence. We know from the past that smoking and alcohol consumption can suppress host resistance to common viral infection, especially the coronavirus. Coronavirus in the past have caused, in other species of coronavirus, can cause respiratory infection in human. And the first viral corona is SARS-CoV-1. Second is the MERS-CoV, and now we encounter the serious one, is the SARS-CoV-2. And also smoking can suppress the host resistance from respiratory syncytial virus and another virus that cause the respiratory infection, such as rhinovirus also. From a systematic review, before the pandemic of SARS-CoV-2 infection, shown that the patient who harbor influenza virus, if they smoke, the disease can progress easily. And there is evidence that antiviral defensibility of the nasal epithelial cell after exposed to tobacco smoke can demonstrate the impair of the function to work against the virus of these epithelial cells. And these nasal epithelial cells can reflect all the epithelial cells all over in our trachea, in our bronchus, bronchiole, and also in our lung. But however, the evidence after the systematic review from China, but when we have more data from South Korea, from Europe, especially in Italy and the UK, and also the data from USA, there were conflicting results about the relationship between the smoking and risk of COVID-19. In my opinion, this may result from there may be the underreport of smoking history by the patients, maybe during the hurdle of the disease, and also in the size of the healthcare worker or the personnel who encounter the patient and recording the history of smoking. Maybe they do not pay so much attention or do not speculate about this history because of the urgency of the disease. So until now, the evidence to strongly support the risk of COVID-19 from smoking may be not clear. But in the point of view of respiratory physician and also general physician, we, with our previous knowledge, smoking should be the risk, one of the risks of COVID-19 infection, and we waiting for more evidence to support this idea. And this is a picture from C et al. And they show that this is common immunopathogenicity of a COVID infection. The key player is the SARS-CoV-2 virus, the angiotensin converting enzyme to receptor. and interleukin 6 and the macrophage. I will talk about this later. And also this picture, and there's another key player is the nicotine receptor. It can, as I mentioned earlier, that nicotine have an anti-inflammatory effect. And in the people who smoke, and when they get the SARS-CoV-2 into their cell, it can increase some biomarker such as mitogen activating protein kinase and also the interleukin 6. Smoking can cause the imbalance of these chemokine, cytokine, inflammatory marker in the cell. But we don't know exactly what the disturbance of these cytokines, which one can progress the prognosis of lung injury, progress the injury, and also inhibit the repairing of the cell after recovery from injury. This is the data from Thailand in our hospital during the first wave of COVID-19 last year. We have 106 patients. Nearly 60% of them were male. And we have record the history of smoking at that time. Overall, the history of smoking is around 20%. It's a little bit lower in the general population. And when we separate into two groups, the patient with the age less than 35 have more history of smoking. This number may be the same all around the world at that time because in the situation of the new disease and dangerous disease, and the patient and also the healthcare worker may pay more attention about the history of smoking. And let's move to the second topic about the prognosis of the disease. In April 2020, WHO announced that smokers are more likely to develop more serious disease. And the evidence from China also shown that current and former smoker was significantly harboring serious illness after they infect with the SARS-CoV-2. And in the patient who have pre-existing chronic lung disease, especially COPD, bronchiectasis, or other cause of lung fibrosis, smoking can potentiate the severity of disease, where the excessive airway secretion impair expectoration and compromise ventilatory function. And also it can potentiate the inflammatory markers. There's evidence from China when they compare among survivor and non-survivor. After adjustment for age, gender, and underlying disease, the smoker tend to have higher risk of mortality. Let's see the curve here. The curve separate clearly after the infection for around 3 weeks. It may be in the patient who develop severe disease requiring ICU admission. And this picture is continued from the other ones, that cigarette smokes can potentiate inflammatory marker, especially mitogen activated protein kinase. It can increase the ACE2 receptor to make more virus into the cell, and it potentiates the interleukin 6 that play vital role in immunopathogenesis of the disease severity. In the tissue culture model, cigarette smoke have evidence to inhibit the airway basal stem cell repairing response. This cell is quite important when we harbor the lung injury or tissue injury from microbial agent or toxic substance, and tobacco smoke can inhibit this repairing, and maybe it results in the severity after the infection. The role of nicotine in tobacco smoke have some vital role. Nicotine can affect homeostasis of the renin-angiotensin system that can upregulate the ACE2 receptor that can making more virus entry into the cell. As I mentioned earlier, nicotine may be initially benefit from acute lung injury, and some researchers have proposed that nicotine may protect the lung. However, nicotine can also increase viral replication and cytoplasmic effect, and overexpression of this marker can progress the lung damage. So the complex interaction between nicotine and lung injury and lung repairing process may depend on the dose of the nicotine. And we must speculate more the evidence about the nicotine and lung injury and lung repairing process after COVID infection. Other aspects of smoking and COVID-19 and smoking hand and cigarette filter may contaminate by SARS-CoV-2, and then when the people gather together, they can pass cross-contamination between them. And during smoking, they may sneeze and cough and propagate the aerosol contain the virus. And during the home quarantine or home isolation, especially in Thailand, we hope that maybe there's chance to potential for smoker to quit smoke. But in the real world, and data reveal that from the negative emotion and anxiety, fearing about the disease, that can cause stress to the patients, and they may smoke more. So this issue is important when the healthcare worker dealing with the patient in the home isolation or home quarantine. They should support psychically for the patient, especially those who smoke, to decrease or stop smoking. This picture gather all the interplay between smoking and COVID-19. And I will touch a little bit about e-cigarettes. There's also evidence from United States that e-cigarettes, the teenager who smoke e-cigarette can harbor more COVID-19 infection. So electronic cigarette and tobacco smoke, conventional tobacco may be the same dangerous to the COVID-19 infection. In my experience, when we counter the patient with COVID-19 pneumonia, those who have smoker, especially here who have we call it the combined pulmonary fibrosis and emphysema, it's maybe difficult for the physician to differentiate between the severity from the present infection or it resulted from the past injury in the lung from smoking. And in some patients who have a history of electronic smoke, the results from the chest X-ray and the CT scan maybe cannot differentiate between these two diseases. This is the problem that we encounter during the caring of the COVID-19 pneumonia patient in Thailand. So in my last slide, I'm bringing it from a colleague in Pakistan. They proposed that during the maybe this is a new normal for smoker during the COVID-19 pandemic infection. Firstly, they should quit or limit tobacco smoking, and during the process of reduce the tobacco smoke, they should practice infection control to prevent the transmission of the virus between smoker and non-smoker by the aerosol. And in the point of view of rescue physician, we should encourage the patients or the people during the COVID pandemic to stop smoking, and those who cannot, there should be the intervention during their home isolation and home quarantine to reduce or stop smoking at that time. Thank you very much.
For contributing your informations and also some study information from this study. May I just make a comment and then one question asked Dr. Nitipat about this. So I think when we talk about the prevalence of smoking among the hospitalized patients with COVID-19, I think there are many confounding factors to determine whether smoking is really protect or really harmful or increase the risk of COVID-19 infections. For example, if in a country where smoking is not endemic, the anti-smoking campaigns is very effective. Maybe the one who a smoker get COVID-19 and then he cough quite a lot, spread the COVID-19 among his family members who are non-smoker. So you see one infected COVID-19 in the smoker spreads a lot of COVID-19 to non-smoker in his family. And then in that case, maybe we see a lot of patients infected with COVID-19, but the prevalence of smoking is something different, okay? So maybe it's a little bit very difficult to interpret that. But as Dr. Nitipat is a doctor who looks after infected patients in respiratory ICU, in ICU in those cases, did you observe that those who had a very severe COVID-19 had a higher prevalence of smoking compared to other countries, even they have the same comorbidity? Did you observe that data?
Yes, it's an interesting question from Professor Amon. And in during the first wave, 106 patients, we only encountered 11 patients in the ICU. The number is quite small to compare those, but there's a tendency of those who smoke have a more severe disease and more mortality. And we now try to gather more information during the past 2 months. There's a lot of patients with severe pneumonia in Thailand, but the data is not complete now.
Especially those smokers that if you get COVID-19, you may have a more severe disease, and you might see Dr. Nitipat at Silat Hospital in the ICU. I hope you don't have that kind of scenario with you. Okay, thank you very much, Dr. Nitipat. So we move on to the next speaker. Yes.
One more question.
One more question, please, from our co-moderator, Dr. Chantra.
Thank you very much for your excellent presentation. I'm Dr. Chantra Chenawasin from Thai Women Association. I saw you mention about try to encourage the stop smoking, the patient, COVID patient, to stop smoking. I think this is a good idea because we all can get them to stop smoking. But how many patients you have success in this program to stop smoking?
And it is my idea to initiate the program to
Thank
help
you.
the patient to stop smoke during the lockdown or during the isolation or quarantine at home. But at present there is no current program to help the people to stop smoking now, and I should in the future, because we must live with the COVID-19 in another 4 months, 6 months ahead, and this program should be in really practice in the future. So.
Regulation and science, and as I see, he's a Greek delegate to the European Commission's Committee on Tobacco Control. He was a recipient of the 2018 Luther Terry Young Pioneer Award, awarded by the American Cancer Society, and the co-chair of the Global Alliance for Chronic Diseases, Lung Diseases Research Program. I think it's morning. You have to wake up and say good morning. So please go on with your lecture. Thank you very much for coming to this APACT 2021.
It's a very good morning from me. Good morning, Professor, and good morning to the APACT 2021 colleagues. It's a pity we're not having an in-person meeting, so it's a pleasure to be in Southeast Asia, and also a very big pleasure to be in Thailand.
Well, later you are welcome later.
It would be a pleasure. It's a very early morning call for me this morning, so apologies if I'm still waking up. It's 5:30 in the morning. So I would like, and thank you for your very generous introduction. Let me share my screen.
Share screen, please.
Yes.
Share screen.
Can you see?
Okay,
yeah. Can you see my
screen?
Coming,
yeah.
Okay, thank you very much. So today, and very shortly, I'd like to present on the prognostic factors that are related to the adverse outcomes of SARS-CoV-2, focusing mainly on the role of smoking. And I'll present today work was done by a large team, so it's not only myself, but I'll be bringing forward some interesting results with regard to how smoking interacts both with its comorbidities that are related to smoking, and of course smoking within the intensive care unit, a good question, and smoking of course within hospitalized patients. So of course we know that the SARS-CoV-2 pandemic we're living at right now, the implications of this pandemic by not having an in-person meeting with you. It's evolved into a pandemic with global outreach and detrimental consequences, both for human life as we know, but also for the economy, public health, and also the healthcare system. And to be able to curb the transmission of the SARS-CoV-2, all governments and medical associations have promoted the reduction of transmission through non-pharmaceutical interventions such as face masks, social distancing, travel bans, and that's been done by the policy side. From an academic side, a lot of research has focused on providing both a better understanding of the SARS-CoV-2, as very nicely presented by the previous presenter, in terms of its clinical characteristics, the symptoms, the severity, which we'll talk about today, but also, very importantly, in the continuity of care of a SARS-CoV-2 patient that does enter the hospital, is triaged from the community to the emergency room, from the emergency room to the hospital room, from the hospital room to an intensive care unit, and etc. So this has all caused a large issue with patient management. And when we have an issue with patient management, this is causing a large strain on the healthcare system. This was very, very evident, especially in the first wave of the pandemic, where the hospitals and intensive care units were relatively unprepared for such a large-scale need for healthcare resources. This leads to a need that has to be addressed, is how to stratify the patients for a better management and the use of resources, as some patients may need oxygen, some other patients may need mechanical ventilation, some may need intensive care unit care. So it's a matter of being able to stratify appropriately the best allocated needs for the best outcomes per patient. Now, of course, these risk factors that we need to identify are those that lead to a seriousness of symptoms, hospital admission, intensive care unit admission, and of course, the very adverse outcome, which is increased mobility and or death. So it's important from a healthcare perspective that we take into account what factors would be able to lead to worse outcomes. So to be able to address some of these questions, and I think before going into the work that we've been doing, just want to highlight, because we've had a lot of discussion on nicotine and its effects on COVID-19, as we mentioned just before. But I think it's important to bring forward an official report that was released by the European Commission, which is the 27 European countries that are part of this European Union. The scientific body, the Joint Research Centre of the European Commission, performed a review of studies that assessed whether the nicotine or smoking has a protective effect against COVID-19 and reanalyzed the data. And they did notice a mismatch between observed smokers. Of course, remember, there's a big issue of as mentioned by the previous speaker, of reporting smoking in such a pandemic. It's literally in the beginning, first waves, it's the equivalent of a polemic situation inside hospitals. So there's a bigger focus, of course, on actual prioritizing stabilizing the patients, and then recording a very detailed health chart. But there was a mismatch in the number of smokers and the number of smokers expected for the cohort size in the general population. However, when the researchers from the Joint Research Committee, the JRC, assessed this in detail, they identified that, for instance, comorbidities such as hypertension, diabetes, and COPD, see that there's a statistically significant difference between the observed prevalence and the prevalence of these in the general population. So it's very likely that, especially in the first wave, because a lot of the discussion was on the first wave of the pandemic, that these patients do not likely reflect the health stats of the general population. Hence, there's an issue of underrepresentativeness in such cohorts, and this was published in TID by Wenzel. So what did we do to be able to look at this next step and to be able to prioritize and give a bit of a feedback on what would be the high-risk groups that we should be assessing? Now, from one perspective, this is useful for public health policy and for management, healthcare management, but from another perspective, it also gives us a unique opportunity to be able to assess the impact of smoking-related diseases and COVID-19, as we also are very, very aware of the impact of smoking on a plethora of diseases and ailments of the human body. We could have at least next 20 minutes just talking about in bullet points, mentioning the diseases related to smoking. But it's very important to assess this interaction. So We performed a systematic review and a meta-analysis, and these results have not been shown ever publicly, so this is the first opportunity to be able to identify and evaluate the impact of pre-existing medical conditions such as ischemic heart disease, COPD, asthma, stroke, dementia, diabetes, dyslipidemia, a lot of other ones which we'll look at in very detail, and assess these prognostic factors related to adverse outcomes. Now, we assess adverse outcomes separately for overall mortality, hospital admission, intensive care unit admission, and we also attempt to be able to assess separately the need for mechanical ventilation and the need for oxygen therapy. So these are done separately, as also acute respiratory distress symptoms. However, today we're focusing on these three: overall mortality, hospital admission, and ICU admission. So in our activities, in our work here, we performed the relevant peer-reviewed studies, which means we did not assess preprints, which has been very popular especially in the first wave of the pandemic. The first wave of the pandemic saw a blooming of preprint servers with its positive aspects, but also its negative aspects. That is a lack of peer review. So we identified relevant peer-reviewed studies through Ovid Medline and Ovid Embase up to July 2020. So this represents the first wave of the pandemic. Of course, screening for reference lists that include articles, systematic reviews, non-systematic reviews for additional relevant studies. Both PRISMA and MOOS guidelines were applied. And what we did also is we assessed a potential overlap, because in the beginning we noted from many studies that, for instance, you have a team that has 100 patients of SARS-CoV-2 and would quickly publish the results and have some preliminary results, and then the same team would publish 6 months later or 5 months later their work on SARS-CoV-2 with 500 patients. So in this case, we only used the populations that were larger, and we also be able to retain the special geographical context of the patients. We focus predominantly on the EU and the US, the Europe and US, for the simple reasons is that they had a very comparable healthcare system and also very comparable availability of intensive care units and tertiary care. So these results here focus mainly on the European countries and the US countries, but it gives an indication. And of course, every study underwent quality appraisal using the Joanna Briggs Institute standardized appraisal tool for cohort studies. Because we're looking at cohort studies, we want to see what is the effect within a cohort study, not cross-sectional. Of course, the results you see right now are going to present, of course, results ratios, but importantly, this is very easy for interpretation, the absolute risk differences in deaths per 1,000 COVID patients. In other words, if you have a COVID-19 patient who has diabetes, what is the absolute risk difference they have? So it's a very measurable number in the number of patients per 1,000. Of course, meta-analysis is adjusted and unadjusted separately, which we'll talk about, and the heterogeneity was assessed and quantified, and also publication bias was evaluated. So in total, within this activity, we included 58 cohort studies, which used data from about 100,000 SARS-CoV-2 patients. This is in the beginning of the first wave of the pandemic. So this information was used initially to be able to fuel some scientific directions and also some policy directions, out of which 10,000 patients were from the community setting, 47,000 patients from 13 studies were in the emergency department setting, and of course another 50,000 almost patients in the hospital setting, and 7,500 in the ICU setting. This is, of course, these are the crude numbers. Some patients were removed for missing information that was not available for all studies, and hence we find 101,000 patients. An important aspect here, and this is something that was not taken always into account by previous systematic reviews, is that we used at least 2 weeks patient follow-up. In other words, if a study had a reported 10 days of intensive care unit or 1 week of intensive care unit or hospital unit, we would not include that, because we assessed that a 2 week period would allow for an outcome either a positive outcome, hospital discharge, or a negative outcome, something that we would follow up from escalation to intensive care unit or death. So we used a 2-week patient follow-up to allow for a window of assessment, which is a very novel aspect. Now, of course, for the results, starting with this, just because we keep on talking about what are the risk factors for SARS-CoV-2 in the scientific channels, in the medical channels, and the discussions, but age by far is the strongest association, of course, and we identified a very strong association between mortality and hospital admission across all settings. In other words, community, emergency department, hospital, and ICU. And of course, if you look at those over 70 versus those under 50, mortality was 21 times higher in the community, 37 times higher in the emergency setting. So they're being rushed to hospital, they enter the emergency room, and those who were assessed at the emergency room and then followed up, 37 times more higher likelihood here, and 7 times higher in the ICU setting. And this large difference between the 20 and 30 and then the 7, which is a very small increase compared to the odds of death in the emergency and community setting, is because the patients that are already in or entering ICU, in any case, are in a very serious condition. So the likelihood of an adverse outcome is unfortunately much higher. So this gives us an idea that whatever study we're looking at, we have to make sure that we're controlling and adjusting for age as a confounder, because this is indeed going to cause a lot of misinterpretation of information. Because when we're talking in the literature, especially in the first wave of the pandemic, there were not too many studies that performed age or adjusted models that would represent the outcomes. But remember, lots of these outcomes are age related. So there's an issue here. One interesting aspect, and this is why before looking at the actual outcomes that were related to comorbidities, we want to assess what's the role of age and gender, because these are usual factors that you control for in adjusted analysis. And interesting that it was very highly statistically significant that male gender, male sex, was identified to be associated with all of the adverse outcomes in all settings, with evidence of moderate or high certainty. So hospitalization rates among males are much more higher. We have an extra 114 hospitalizations per 1,000 patients, and also hospitalizations for the community setting were much higher, another 138 per 1,000 male cases. So this should take into account two things, though, that gender here, in this case, may be a proxy for underlying disease, or even a proxy for risky health behaviors. As for instance, one could hypothesize that tobacco use is much higher in a number of jurisdictions in the world, a number of areas in the world, among males. So what we're seeing here is it possible that this male gender, since there may not be a biological mechanism here, is it actually reflecting underlying disease and risky health behaviors, or the causal chain between risky health behaviors, such as smoking, underlying diseases, and then adverse outcomes? So if we were to look specifically what is the mortality by prognostic factor for smoking-related diseases, then we have the following meta-analysis. Some diamonds may be small, but the essence of information can talk about. So this is a very detailed slide, lots of information on the slide. You don't have to look at all the information that's available. So this is the association between the prognostic factors and mortality among COVID cases in the community. Now, in my presentations, the left of the screen are unadjusted analysis, and the right of the screen are adjusted analysis, at least age and gender adjusted. And on the far right, we've performed a grade assessment of the level of evidence. Now, when we're looking at level of evidence, we have low, moderate, and high. And it's important to note that the moderate and high indicate that the direction of the association is not likely to change. And when we're talking about high grade assessment, it means that the magnitude of also is most likely not going to change, which means when we see an association, it's probably going to be that even later on. So we've looked at lots of different information. You can see here, for instance, automatically any cardiovascular disease, one of my mouse works. You can see any cardiovascular disease is far to the right of the line, such also diabetes, which is a very clear-cut aspect, heart failure, stroke, and then we have, of course, aspects such as cancer, end-stage renal disease, and then other indexes such as here, for instance, polypharmacy, which is probably a proxy of multimorbidities and comorbidities. And same here, having a number of one or at least two multimorbidity conditions relate to a higher likelihood of mortality from the community setting. But when we look at those that are age and gender adjusted, of course, the level of information is much smaller, and we see predominantly, for instance, diabetes. We have any cardiovascular disease with diabetes, and we have heart failure, for instance, any respiratory disease, which is a very broad category, of course, linked to the adverse mortality within cases in the community. Looking at of course, the mortality for those that reach the emergency setting. So the previous slide was those adults that reach the community, those adults that are recruited in the community setting and then have followed up to see what happens to them. This now slide indicates the association between prognostic factors among those that actually reach the hospital. So these enter the hospital ward. You can imagine also the case at this time when this information has been recorded. They enter the emergency department, and you can see this is the prognostic factors for mortality in the emergency setting. And we can see automatically that we have a much higher risk. So those that are taken to the emergency department also at a very higher risk for mortality, of course. And we see here, again, cardiovascular diseases, heart failure, hypertension, ischemic heart disease, there's a 2.7 odds ratio, COPD, renal disease, and then we have other factors. Now, I have some slides, current smoking and past smoking, but I'll talk specifically about them towards the end and why we're seeing this type of information. And this is, of course, the biggest slide of the day, just to indicate the plethora of information. I could have shown just a snippet, but I want to show you the whole screen to show you exactly that all types of factors that are tobacco related or assessed. Again, you can see those that are on the right of the line show an association. On the left is those that are unadjusted, and the right are adjusted. But I won't show the whole thing here. I'll talk about it in a specific slide. I think it's easier. So for these hospital mortalities I just mentioned, excuse me, there is evidence of high certainty that in at least age and gender adjusted analysis, we have a high certainty, which means the direction is correct, but also the magnitude of association is correct. For diabetes, which we know its association with smoking, it's directly related, renal diseases, and this all comes in with the whole aspect of cardiovascular, and it's mainly vascular disease also as well. So diabetes mellitus, renal disease, and dementia. Of course, dementia is directly linked to tobacco use, and those who are tobacco users are at a high risk for developing dementia. So these are factors that are all being able to potentially brought forward by also tobacco use. And there's moderate certainty evidence, which means that the direction is correct, but maybe the magnitude of association is not, is for ischemic heart disease, again, directly related to tobacco use, stroke, solid organ tumors, cancer in other words, and obesity, of which only potentially obesity to some extent is not associated here with smoking. All the rest is directly associated with smoking-related diseases. So we see a large burden. But what about those mortality in the intensive care unit? Of course, things here are different due to the fact that the sample size is smaller and the studies are smaller. Again, we see that a higher mortality among patients with diabetes, dyslipidemia, ischemic heart disease, COPD, of course, very primary tobacco-related disease here, and then, of course, cancer, renal disease, end-stage renal diseases, and other factors, including the number of comorbidities. So this is within ICU. But what about entering the hospital, because remember we said at the beginning we're looking at death and mortality, which is a very hard and unfortunate outcome, but there's also the outcome of putting strain on the healthcare system, and that is hospital and ICU admission. We all remember the first wave of the pandemic, how difficult patient management was at the hospital level and intensive care unit level, with a large number of deaths, also probably for the matter of triaging patients of where do we have enough ventilators available. So it's important to see how smoking is related to this entrance into the ICU. So for hospital admission, on the left is unadjusted analysis, and on the right are at least age gender adjusted analysis, and we see a high level of association for male gender and a moderate association for cardiovascular disease, diabetes, COPD, and borderline non-specific differences for renal disease. So we see that we have, again, cardiovascular disease, diabetes, and COPD directly linked to hospital admission. So these patients, and of course these three diseases are very highly tobacco related, I would use that term. So this is putting an extra strain due to these types of patients. And for intensive care unit admission, of course, things are more difficult here, but as you see, with regards to the additional patients, those, of course, the male genders was mentioned, any cardiovascular disease is 3.5 times more likely to be into ICU, diabetes, heart failure, hypertension, COPD, cancer, and then, of course, obesity and other morbidities related to admission to the ICU. So again, we're seeing a list of diseases that are tobacco related that lead to a higher risk for admission. Of course, as soon as you enter the ICU, you have, of course, a high level of care, but due to the usual mechanical ventilation, intubation, you have a higher risk, of course, for other complications of the actual process and procedure, and being mechanically ventilated for a week, 2 weeks during this unfortunate time. So we see, for instance, if you look at the absolute risk difference that we have for heart failure, there's 431 more patients per 1,000 when you have heart failure, 325 more patients per 1,000 with COPD. So it's a matter of large numbers. It's not only a risk factor of 3 or 5. We're talking about a few more hundred patients per 1,000. So it's a big strain. This is a heat chart just to show where we stand with regards to the different associations between and where there's evidence for an association between an adverse outcome and mortality or admission. Red indicates a very strong outcome, and the pink weaker but still significant. Green was no effect, usually due to sample size, and inadequate data again that's not available, as was white. So the strength of this meta-analysis is that while previous meta-analysis had evaluated different prognostic factors and pulled together the adverse outcomes like death, ventilation, and ICU together. So it's either death or ventilation. But it's very different when you have a pooled composite outcome, death or ventilation or ICU, and different when you say death, ventilation, ICU. It's a very different patient process when you have these three. Of course, we also rigorously and transparently evaluated the certainty of the evidence behind each of the meta-analysis using grade, which is very important. That's why we have this high, moderate, and low grading, and where possible, age gender adjusted analysis. However, the limitations that we, as I said, we've excluded non-peer review preprint literature. In some cases, the preprint literature is useful. In some cases, it's not very useful due to the fact it's not peer reviewed. Of course, this information described today restricts to Europe, USA, Canada, Australia, New Zealand, because they had comparable in a hospital system and ICU systems. That does not mean that this is generalizable to the whole planet, but it does give an indication because the biological mechanisms of COPD and cardiovascular disease and cancer are very similar. There is, though, a heterogeneity in some risk factor definitions, but such as hypertension. So how do we define hypertension in those cases? Or obesity? Is it a BMI above 25, 30, 35, 40? it depends. Many changes were noted within the research at this wave. And of course, we can't, even though we can see that there's associations, we can't compare between, do comparative ranking between risk factors. So the main finding for the mortality was the high certainty evidence in at least age and gender-adjusted analysis for diabetes, renal disease, and dementia, and moderate certainty evidence for ischemic heart disease, stroke, tumors, and obesity. And of course, all of these, most of these are directly related to tobacco use. And in the community-based mortality, it's a history of heart failure, stroke, diabetes, and end-stage renal disease, all again potentially related to tobacco use. And for the hospitalization, the main finding is that you have high or moderate certainty of the evidence for a strong association between hospitalization for COVID-19 and diabetes, heart failure, COPD, renal disease, obesity, and ischemic heart disease again. So you're saying that this is a type of patient that is has a large number of comorbidities that are related to, or have comorbidities that are related to tobacco-induced disease. So just to wrap up 3 more slides, I think it's important to see that we had received, and also it's a very interesting systematic review of meta-analysis that was published in TID on the association between smoking and negative outcomes among COVID-19 patients. It's a paper from Thailand, a number of authors. This was also an infographic video, which I could not embed to press play, but you can find it online. But in principle, they looked at smoking and the risk of negative outcomes among COVID-19 patients, a systematic review meta-analysis, and identified that both current smoking and former smoking significantly increase the risk of disease severity, and current smoking and former smoking also significantly increase the risk of death. So this is confirming it from another perspective, looking specifically at smoking, and we were looking specifically at smoking-related diseases. So these are 2 sides of the coin that bring forward and indicate the importance of the detrimental role of smoking in adverse outcomes here. I think so. In conclusion, that tobacco-associated, tobacco-related diseases are directly associated with mortality due to COVID-19. And tobacco use in its current and former form is directly associated with mortality. And tobacco use in current and former form are directly associated with disease severity for SARS-CoV-2. So just have to acknowledge a large number of participants and researchers that worked with us on this systematic review. And this, of course, this is a personal position and does not represent the default, the position of the contracting authorities here. And I think it's very important, since I have the opportunity to say so, is that please log on and see that the APACT 2021 abstract book is online and published in tobacco-induced diseases. It's been a pleasure to collaborate with APACT on this activity, and it's available fully online in PDF and in HTML format, where you can download the complete PDF book. Thank you very much. It's been a pleasure, and looking forward to discussing and hopefully meeting soon again in Thailand. Thank you very much.
Welcome. I think the message, and then you already sent in the conclusion, is very clear that smoking is really a risk factor for infection, for severity of the disease, and also for the ICU admissions. And thank you very much for you very hard work collecting more than 100,000 cases and analyze it. And what we see here, may I just ask you do in your analysis, you show that age is really a strongest factor that related to the severity and mortality and COVID-19. And if I just postulate that because older age, that we have a organ impairment, degenerations according to the age compared to the under 80 years old. And if someone had a smoking history longer than, let's say, 5 years or 10 years, it's not a current time. You see a higher severity, in COVID-19, let's say pneumonia, and higher mortality in those smoker who had a long history of smoking, and that will cause a damage to the organ that you already show in your slide, that the mortality and the severity of disease already related to the smoking. Let's say cardiovascular disease, pneumonia, can be also postulated that because if you smoke longer, let's say more than 5 years, then you are very in a higher risk of acquiring a severe disease. Can we also conclude that?
Yes, thank you, Professor, for your comment. Indeed, I think it's very important to stress that we could not assess in our analysis the impact of PAC years. However, there's undisputed scientific research that shows that PAC years do relate to disease severity for underlying medical conditions, COPD, and other cardiovascular diseases, respiratory diseases, vascular diseases. So an increasing number of PAC years increases the severity of an underlying condition, and it's likely that, of course, this same association would come from against smoking diseases and SARS-CoV-2. There's a very plausible biological mechanisms for this and very well published evidence. So absolutely agree. It would be a pleasure. Thank you very much for the invitation. It's been an honor to present today, and it's an honor to present in APACT and an honor to present in today's session. Thank you very much.
You see San Francisco, I think. Professor Grant is also a globally recognized expert on e-cigarette, and he is applying his understanding of the tobacco industry to the emerging marijuana industry as well as the sugar industry. I think I don't have to introduce him too much because we are now running out of time. So I think I would like to show his presentation. I think in video. Yes, please go on, please.
UC San Francisco.
So he talked about
I'm going
smoking.
to summarize what we know about smoking, vaping, and COVID-19. This is a paper that Katie Patnavich and I published last year, which is a meta-analysis of the effect of our history of smoking, either current or past smoking, on COVID disease progression, defined as increasing odds of being in an ICU, death, or things like that. And what we found, based on the studies summarized here, is that people with a history of smoking had about a 1.9 times increase in the odds of serious COVID disease progression. Since then, there have been more studies published, and this is from an updated meta-analysis that Katie and I have coming out in BMC Public Health. And you can see that adding more studies in still showed a significant association between ever smoking and COVID disease progression, here of about a factor of 1.6. Since then, there have been other meta-analyses published as the number of studies looking at this question continues to accumulate, and they're all consistently showing about a 1.5 to doubling of the odds of disease progression among people diagnosed with COVID with a history of smoking. So there's, at this point, really no question that if you are or were a smoker and you get COVID, you're going to do worse. This is another slide from the updated meta-analysis that Katie Patnavich and I have coming out, looking at the association between current or former smoking and COVID-19 mortality among people diagnosed with COVID. And you see about a 1.2 factor increase in the odds of death among people diagnosed with COVID who have a history of smoking. And again, since we did this work, there have been more studies published which are continuing to show that once you get COVID, if you have a history of smoking, your odds of doing worse, including dying, are increased. Another thing that we found in the meta-analysis is there seems to be an age effect, where the effect of smoking is actually larger among younger people than among older people. This is similar to what's found with heart disease, where smoking increases the risks of developing heart disease or having a heart attack more among younger smokers than older smokers. The risks are still increased, but but by much more among younger people. So, what do we know about the underlying biology that would lead you to expect that smoking would affect COVID risks? Well, smoking does a lot of bad things to the respiratory system and its immune functions. Smoking damages or destroys cilia, which are the very tiny hairs lining your nose and upper airways. The cilia capture and expel viruses and bacteria. So if your cilia are not there or not functioning, it's going to be easier for viruses to get down into your respiratory system and infect you. Smoking depresses the innate immune function in the lungs, and so with less immune power in the lungs, you're going to be more susceptible to developing a respiratory infection. Smoking also causes pulmonary inflammation, which affects how the body responds to infectious agents. Now, there's not as much evidence about e-cigarettes as we have for smoking, but to the extent that people have been looking at e-cigarettes, they have a lot of these similar adverse effects on respiratory immunology. And so while we don't have direct epidemiological evidence yet, you would think that e-cigarettes would also increase adverse outcomes among people with COVID. Another thing that's very important is that smoking upregulates the ACE2 receptor. The ACE2 receptor is the doorway that lets COVID into cells, or lets the coronavirus into cells, where it can then infect them and hijack the cell's molecular structure and reproduce the virus. Interestingly, if you quit smoking, the ACE receptor sites are downregulated. So smoking is going to increase the opportunities for infection. And there's a lot of details that have been worked out in terms of the molecular signaling here, and it's very clear that smoking is adversely affecting the ACE2 receptors in terms of increasing the odds of being infected. And in fact, there's recent animal studies with e-cigarettes showing the same thing, that e-cigarette exposures associated with increased ACE2 upregulation. So all of this would lead you to expect that smoking and probably vaping would increase the risk of COVID infection. Everything I've been talking about so far has been the risk of serious outcomes once you're infected. But, you know, this would all lead you to think that smoking and probably vaping would increase the risk of getting infected. There's also direct studies of infections with the flu virus and the MERS virus, which show that smokers are at increased risk of infection. But oddly enough, there are a lot of studies showing that there's less reported smoking among people with documented COVID than people who don't have COVID. And this has led to something called the nicotine hypothesis, which is that nicotine is somehow protective against COVID, perhaps by downregulating the ACE2 receptor or nicotine's anti-inflammatory properties. But in looking at this, there are a lot of difficulties in interpreting the studies of smoking and COVID infection, mostly growing out of the fact that most of the studies are of people who've been tested for COVID, and they're not population-based studies, and so there's lots of room for biases in the samples, because if you're limiting the studies to people who are tested, testing is not randomly distributed across the population, and you're going to end up with people who are at higher risk, perhaps because they're healthcare workers with higher risk of exposure, or because they have existing conditions that increase their risk of developing COVID. And these risk factors for COVID, like heart disease, lung disease, diabetes, and other problems, are caused by smoking. And so there's a tremendous confounding between smoking as a direct cause of COVID infection and smoking as an indirect cause through mediated by creating these other diseases. Another problem is that the assessment of smoking in these studies is sometimes not very good, especially if you're looking at people who are hospitalized with COVID, because they're coming in very often very sick, and the medical system overall doesn't do a very good job of assessing smoking behavior, especially in acute care settings. And so there's probably a lot of inaccurate reporting. Another thing that complicates the picture is the tobacco industry. This is a paper that was in BMJ recently, which showed that a couple of the very high-profile papers asserting that smoking was protective against COVID and presenting the nicotine hypothesis in particular were with people who had undisclosed linkages with the tobacco industry. And in fact, one of the papers that had been widely touted ended up being retracted by the journal that published it because of a failure to accurately report conflicts of interest and linkages to tobacco-related organizations. So that adds just another layer of confusion into these studies about smoking and vaping and COVID infection risk. Of the studies that I've seen looking at the question of infection risk, though, I think this one from the UK is probably the most interesting and informative one. This was a study of 2.4 million people in the UK who had downloaded an app in which they could report COVID symptoms. So it wasn't limited to patients. It was a broad sample from the population as a whole. Now, it's not a random sample because you had to download the app, but at least it was a very broad population-based sample. And the authors of this study did try to control for demographics. And what they found among this very large population sample is that people who smoked were more likely to report COVID symptoms and more COVID symptoms. And this is looking at the odds of reporting COVID symptoms as a function of current smoking controlling for a range of demographics. And you can see that smoking was associated with more symptoms. They also looked at the subset of this sample of people who actually were tested for COVID. And this analysis really points to and highlights the problems of most of the other studies, which were limited to people who were tested for COVID. The first thing they found is that of the people who were tested, 20% of them were healthcare workers, compared to 3.4% of the general population who are healthcare workers. Now, that's not surprising because people who work in healthcare are at increased risk of exposure to COVID because they're taking care of sick people. And that makes them more likely to be monitored and tested. But it does say that the tested population is not a random sample of the entire population. Also, they found that an even higher fraction of the people who were tested, that tested positive, were healthcare workers. So that's introducing a distortion into samples that are just based on tested people. They also found that the comorbidities, lung disease, heart disease, cancer, diabetes, were higher in the tested individuals than the general population, which is consistent with the view that people at higher risk are more likely to be tested. But they also found that the smoking rates among the people who were tested was lower than the general population in their study. So, which may reflect the fact that they have more healthcare workers. I don't know. But it's showing that the tested population is not really representative of the population as a whole. And in fact, among the people who were tested, smoking was negatively associated with a positive PCR test for COVID infection. And which would be interpreted as saying smoking is protective. But I think there's a very good chance that this result is an artifact of the fact that the sample is not a representative sample of the population as a whole. So the difference between the results when they were just looking at people who were tested versus the slide I showed before, which is everybody in their study, which showed the opposite effect, that smoking was associated with more COVID symptoms. Another thing that they found was that the symptom burden of COVID among the people who were tested was higher among the smokers. So that's consistent with the earlier results that I showed you that showed that smoking makes COVID worse once you're infected. And they speculated that it may be that smoking just shifts the entire distribution of disease risks, not just the chance of infection. But, they also point out that the results may just reflect the kind of sampling bias I was talking about earlier. So to me, the bottom line so far is that I think we can be pretty confident in saying that smoking increases the risk of serious COVID once you're diagnosed. There's good reasons in the biology to expect that smoking would increase risk of infection, but that fact hasn't been nailed down yet in the epidemiology. There's not a lot of studies of e-cigarettes and COVID, but this was an interesting population survey of youth and young adults aged 13 to 24, which found that people who had a history of dual use of cigarettes and e-cigarettes were at significantly increased risk of a COVID diagnosis among these youth. And in terms of both cigarettes only and e-cigarettes only, there were also increases in the point estimates of risk, but the confidence intervals were often pretty broad because the numbers were very small. Dual use is the most common use pattern in this sample, so you had the most cases. But this certainly is consistent with what you would expect based on what we know about the biology of the effects of e-cigarettes on lungs and pulmonary immune function. So what's the bottom line of all of this? Well, as I said, I think we can be quite confident in the statement that smoking makes COVID-19 worse once you're infected. There's lots of reasons to think that smoking would increase the risk of infection, and there's some evidence to support that, but I think it's still not nailed down. To answer the infection question in particular, we need to get a better assessment of smoking and passive smoking exposure, as well as other inhalation insults like e-cigarette use and marijuana use. And we need population-based samples to determine infection risks so that we're looking at the population as a whole, not just people who have gotten tested. But based on what we do know, I think we can say with a high level of confidence that reducing smoking and probably vaping would reduce the COVID-19 burden by making the disease people get less severe and probably in decreasing the chances that they were going to get infected.
So that's the end of the presentation by Professor Stockton Grants, and I think the bottom line that he sent a message for us is really clear that any epidemiological study that show the results or relationship between COVID-19 and smoking is really subject by many confounding factors and bias, even sampling bias and on those things. But I think the last sentence that Professor Stockton already mentioned is quite clear that if reducing smoking and probably vaping could reduce COVID-19 infection, I think this is a message that's quite clear for us. I think that the time, but I have one question from participants online. Could you mention a bit about the COVID-19 and vaccine, whether vaccination with COVID-19 is less effective in smoker? Dr. Nitipat, can you mention a little bit about that?
Yes.
Whether, yes.
Theoretically, maybe those who smoke maybe have some disturbance of immune regulation in their body, and the effectiveness of vaccine may be reduced. But I think in the real world, the gathering data about the immune response in those who smoke or non-smoker is an issue of interest in the future. Thank you.
Okay, thank you very much. So it's just a hypothesis or speculation that it's really perhaps the immune response to vaccination may not be affected by smoking, but once smoker get infected with COVID-19, they will has a higher risk of getting more severe disease. That's the information that we have right now, but we really don't have a good study that the mind control try to answer these questions. I think there is no more comments or questions from our participants online, so I would like to close this session, and thank you very much for our three speakers, one from Thailand, and the other two from other countries, from UC San Diego, and also from Harvard and from Greek. And I think everyone get the message clear that smoking, even though the study may be a little bit confusing, but it's a increased risk of severity of COVID-19, whether the admission to the ICU or to the mortality. So thank you, and we close this session.